A strange thing has happened to men over the past few decades. We've become increasingly infertile, so much so that within a generation, we may lose the ability to reproduce entirely. What's causing this mysterious drop in sperm counts? And is there any way to reverse it before it's too late is unknown. This is an article from GQ, which is, of course, my preferred scientific journal. But it's well referenced in a very interesting article. I think it's perhaps a little bit overstated, but nonetheless very interesting. You know, we live in the United States of America, and we have this really high rate of coronary artery disease, and we think it's normal and everybody has it. But if you go to other countries, they don't have it. And yet, we're told by our cardiologist to go ahead and pretty much eat whatever you want. Seems wrong. Well, who are we? I'm going to show you in a minute that you're probably the average of your 5 closest friends. But in addition to that, you are the totality of your exposome and what you can't detoxify. And that exposome includes your food and your water and your air and everything that's in it. But it also includes your thoughts and your beliefs. You are your exposome and what you can't detoxify. So research into systems biology is really important because the reductionist model doesn't work, because you start with a group. You get 1,000 people recruited for your study, and 400 of them don't meet your exclusion criteria, so they're gone. Another 300 don't meet your inclusion criteria, so they're gone. So now you're left with 300 people in your study. We don't do that. We don't include and exclude, so we take all comers. So if you really carefully analyze the research, it rarely actually applies to your patient. In clinical practice, we have to piece together all of the parts, because there is no study that combines 4 or 5 different things. So we have to do it ourselves on the fly. There are inherent limitations in translation of research into clinical practice. So we need more of this systems approach. And the drugs, how well did the drugs really work? Here's a study which showed that lowering glucose actually caused more harm. In fact, there have been 200,000 more deaths in the United States since 1999 because of the tight blood sugar control idea. And in the Cleveland Clinic, about 40% of the patients have 10 or more meds. And we've known for a long time that lifestyle is actually better than drugs in almost every instance. But again, we don't give the patients the tools necessary to start and maintain. You know, what do you do in an interventional trial? You tell them to do something and they're really good at it for 6 weeks, and then the effects fall off so that at 1 year they've gained all the weight back or their metabolic issues have changed. And it's because they haven't been given any long-term tools. You have to change community in order to make lasting change. Here's an example of that. Here's an example of a dietary intervention. 60% of these patients actually reversed their type 2 diabetes. 94% of these patients reduced or eliminated their insulin. Their average hemoglobin A1C improved by 1.3%. They had about a 30-pound weight loss at 1 year, and 3 or more metabolic conditions improved. Now, admittedly, this is an open-label, non-randomized controlled trial. So it's not the best evidence available, but it's also interesting and should be looked at. And here is the website for that, and it's really just a nutritional intervention. So do drugs really fix diabetes? No, they don't. They increase your risk of heart disease and or have no benefit to risk reduction. So what about statins? You know, statins, there may be as much as an 87% increase in type 2 diabetes while on statins. It's interesting because in the papers they give you the relative statistical benefit of the statin, 37%, and they give you the absolute risk, which was like 1%. So it looks like, oh, it's really beneficial and it's not very dangerous. But when you convert the risk to both of them being either relative or absolute, they're almost the same. So, we've got these wonder drugs, Lipitor, and we unfortunately have diabetes medicines that cause heart attacks and Lipitor that causes diabetes. So we've really got Pharmageddon. And it ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. We've got a problem with the fox-hedgehog ratio. The fox knows many things, but the hedgehog knows one big thing. And it's really the difference between complex versus complexity. A rocket ship is complicated. There's lots of parts, but you pretty much know when you flip the switch, a really big fire is going to come out the other end. A human body is chaotic. You can't always predict what's going to happen from the initial conditions. So complex, one can understand the final condition by understanding the initial condition. It's linear. Whereas in complexity, the final conditions are not understood by understanding the initial conditions, and it displays chaos. Complex issues are not merely sets of discrete elements. If we are to have a genuine and lasting effect on obesity and other chronic disease, we need to change the fox-hedgehog ratio, develop our understanding of complex adaptive systems, build on the biomedical paradigm, and move beyond linear thinking. So now that you're depressed, what are we going to do? So as the infomercial says, but wait, there's more. We have a plan. So let's try to understand broadly how to apply the concepts of patient-centered care for patients with chronic complex disease. And we have these tools, and these tools are really designed to capture this complexity. So you've seen this, and we've talked about antecedents, triggers, and mediators, and Dr. Hughes is going to go through that in a lot of detail, but we've also have these 10 metaphysiological areas on the matrix and then the modifiable lifestyle factors below. And this is just a tool to help us capture some of this complexity. So functional medicine is this whole systems and balanced approach. We want to remove what causes imbalance, and we want to provide what creates imbalance. But there's a few details, and it's really not about is it nature or is it nurture. The answer is yes and. And what we're really looking at, among other things, but generally speaking, is this idea of the exposome. Here is a group of Pima Indians, and you can see rippling muscles and, very fit human beings. But this is generally what we looked like today. And unfortunately, the Pima Indians, because of some uniquenesses in their genes and some epigenetic effects, have the highest rate of obesity and diabetes of any population studied. And doesn't that look a little bit like this picture? It's probably not their genes, right? It's something very different. So, we have these concepts of emergence. This is, how are our genes sort of influencing our health and disease. Exposome, we just talked about. Epigenetics, I think you understand. Nutrition or nutrigenomics, how does nutrition influence our genes and what epigenetic effects do they have? And then sociogenomics. Chronic disease results from the emergence of disturbances in metabolism. Lifestyle and environment are the major factor altering gene expression. Now researchers have shown with robust evidence that not only the inherited DNA itself, but also inherited epigenetic instructions contribute to regulating gene expression in offspring, and that's really what we saw in those mice. So how can food influence human biology? Well, energy, obviously, macronutrients, and we can argue all day about which diet is the right macronutrient thing. I'll have something to say about that in a minute. Micronutrients, fiber, phytonutrients, plant genome, anti-nutrients, Epigenetic influences on the microbiome. And people say, there's obviously one right diet, right? For humans, there's obviously one right diet. And whether you believe it's the vegan diet or the meatitarian diet, there's only one right diet. Except probably not, right? Humans have been very adaptable. We have adapted to every climate on the planet. I think it's important to eat things that were alive recently. And I think it's important to eat things that maybe pre-industrial revolution humans would recognize as food. And beyond that, I think it's details. But food is truly information. Here it comes. And we consume a few terabytes of this information every day. So, we really think about food when we're looking at lifestyle. We need to rethink. So again, the hypothesis is that diseases don't exist. And instead we have this. All of the disciplines come in to the middle of the tree at signs and symptoms. And in conventional medicine, we climb the tree and we find cardiology. And then from cardiology, we figure out, well, this is acute coronary syndrome, and we send you to the cath lab, and we figure out it's chronic coronary artery disease, and we put you on a bunch of meds. In functional medicine, we make that same climb, and we figure out the best diagnosis we can have. And our patients come, as I said before, with 10 or 12 diagnoses, and we vet them, and we try to say, listen, these, you don't have those. We did the tests, we did the surveys, we did everything we know how to do. It does not appear that your cluster of symptoms fits those diagnoses. You might be able to say, but you do have this, or you might just be left with, it could be this or that, and you're not at a place where we can make that diagnostic determination yet. But we're not going to wait. We're not going to wait until you have a diagnosis so that we can treat you. We're going to start climbing down the tree. We're going to go back down to those fundamental organizing system and core clinical imbalances, and we're going to try to get underneath that to those antecedents, triggers, and mediators. We're going to try to get underneath that to those genetic predispositions and those epigenetic influences. We're going to try to get underneath that to experiences and attitudes and beliefs, and even deeper than that into their fundamental lifestyle, modifiable lifestyle issues. And we're going to start treating these people even before we know what the disease is. Or if we know what the disease is, we're going to treat that. And we're going to do it through using the tools. And we're going to abandon the idea that one cause, one disease. And we're going to realize that depression is probably not just a Prozac deficiency. And it may be multifactorial in nearly all of our patients. Functional medicine is a disruptive technology that will overthrow the tyranny of the diagnosis. So here at the Institute, we have tools. We have all of this complexity that we map to these tools to help us see patterns. And we think about these networks of function and causality. We think about architecture of thinking and evaluation. We think about these two questions. What do they have too much? What do they have not enough? What do they need to get rid of? What do they need more of? We think about environment as a primary cause. We think about the basic ingredients of optimal health. We think about these 10 core clinical systems. And we use these tools that Dr. Hughes is going to go through in detail. Our principles, we think about biochemical individuality. In some instances, there is 1,000% difference between what one SNP will do and what the next SNP will do, and what one person's epigenetic effects are and the other person's epigenetic effects are. So each of us is unique, and that's why only about 30 to 40% of drugs work really well in any one individual. We think about patient-centered, not disease-centered. It's not the gallbladder down in 238. It's Mrs. Jones and her unique life and how she is currently struggling with gallbladder issues, right? We think about the dynamic balance between external factors and internal factors. We think about this web-like interaction where when you pull on one piece of the web, all of the rest of the web is distorted. So after that intervention, you need to reevaluate to determine the next intervention. And we think about health as not the absence of the disease, but health as a positive vitality. And then, as I talked about before with my dad and my son, we want to enhance organ reserve. 2 questions. What does this patient need more of? What does this patient need to get rid of? So what do they need to get rid of? You know, well, first of all, we'd like to avoid bad things, but sometimes you can't. Sometimes there are things in our water, or in the air, or in our food that we're maybe even unaware of. And so we need to optimize detoxification because you are the product of your entire exposome that you can't detoxify. And then what does this person have in terms of an unmet individual need? And we're not just talking about biochemistry here. What about John from the beginning of this talk? What about John and his dad? What individual needs does he have regarding a sense of belonging, a sense of place, a sense of love, a sense of being enough? We think about toxins and allergens and microbes and stress and poor diet. And we think about the ingredients for optimal health. We think about, you know, in my practice we talk about clean light, clean air, clean water, clean food. 4 things. And, you know, so foods, vitamins, light, water, air, movement, sleep, rhythm. And what kind of rhythm are we talking about? Well, certainly circadian rhythms, but what about the rhythm of poetry, the poetry of their own life? What about the rhythm of movement? Restoration, love, community, connection, meaning, and purpose. And I will tell you that this love, community, connection, meaning, and purpose is more powerful than any other biomarker. This is more powerful, and I'll show you in a minute, than their cholesterol. In functional medicine, we often have a 1,000-piece puzzle. All of the edge pieces are missing. A third of all the other pieces are also missing. And yet we need to be able to create this picture. We need to live within this uncertainty with our patients because we need to master clinical medicine, which is really about mastering the story. And when I say mastering the story, we need to learn to tell this patient's story to them the way Spielberg would tell it, the way Hemingway would tell it, not the way we learned in medical school. We need to master these tools. We need to become master diagnosticians because our patients have too much baggage that we need to help them unload. And then we need to master these new therapies, these new low-risk, potentially high-benefit therapies. So that's really the same as mastering functional medicine. And it's the same as mastering medicine. We need to master these tools, these stories, these therapies, because we're trying to get people to do things that are very, very difficult. A story, a really Freudian-like story in my practice. This young woman comes to me and she has some issues and we work it up and it turns out it looks like it's gluten as one of the elements. So I put her on an elimination diet and she comes back and hasn't done the elimination diet and we have a conversation and too busy, blah, blah, blah. Okay, well, let's try it again. Comes back, hasn't done it. Okay, well, what's going on? I'm still busy. So she goes away and comes back and still hasn't done it. And I say, okay, well, you know, you've come to a guy who tries to treat disease with diet and lifestyle, and you've been unwilling to do diet or lifestyle. So what do we need to do different? What's happening here? And she starts bawling. It finally comes out that her mom used to give her milk toast when she was sick. Her mother passed away when she was 10 years old, and her most prescient memory of her mother is milk toast. She couldn't give away her mother. So we talked about it. And slowly, over several visits, not like an epiphany in one moment, but over several visits, she slowly realized her mother did not care about milquetoast. Her mother cared about her being well. So, she became the most compliant patient I probably ever had. Because we listened to her story repeatedly. So the art of mastering the story is really listening and discovering through dialogue, not through heckling. Interrupting every 19.2 nanoseconds is heckling. Right? We're dialoguing. We'd like to let them talk. Let them finish. Be thinking about what they're talking about, and then when they're done talking, think about what you want to ask. That's how real conversations are supposed to happen. Be inclusive rather than exclusive. You know, in acute care, we want to get to the diagnosis, so we don't care about all this detail. We want to get to the diagnosis, lock down the physiology, and save their life. But that's not what we're doing here. We're trying to understand their life. Look for patterns. Look for connections. Remember, thinking and linking, not naming and blaming. Assess the readiness to change, because you can have the best possible ideas, and if the patient is unready to do them, it's not going to happen. Ask unexpected questions. All the things that were little elements in the history that I talked about with John earlier. I want to take the last 10 minutes of my talk, because I'm going to say something. I'm going to have another chance to talk to you guys later this afternoon. What I want to do now is I want to have a conversation at your tables about, what do you mean you don't treat disease, you treat patients and their unique relationship to the environment? That's sort of a non sequitur if you're new to functional medicine. Because, you know, most holistic modalities are really green pharmacy, right? I don't use Prozac. I use St. John's wort. I don't use NSAIDs. I use whatever, curry. I don't use Lipitor. I use red yeast rice. That's not functional medicine. That's green pharmacy. This is fundamentally different. This is the candle light bulb difference. Fundamentally different. How could it possibly be true that we're treating the patient and their unique relationship to the environment and not their disease? How is it that functional medicine, how could that make any possible sense at all? And just wrestle with that idea, because that's the core fundamental issue in functional medicine. I just want to tell you a little story. This is a very interesting book, if you want to pick it up. The story of this town. This is a town in Pennsylvania. It's a mining community. It's inhabited by Belgians and Italians. And the history of the town is that they needed more workers, so they really recruited basically this entire town from Italy to come live and work here. And the Italian culture from this community was multi-generational homes and community meals and lots of support and this real sense of family and community. So the local doctor realized that the Belgians kind of had the normal amount of heart disease because of their hard lifestyle, and he started thinking, well, something's going on with these Italian people because they're not having heart attacks. So that led to him investigating and then calling in colleagues from the university, and it led to a decades-long investigation. And they thought, well, gosh, maybe it's their diet. So they looked at their diet, and it was, high fat and a lot of simplified carbohydrates, and basically it wasn't that different from the standard American diet. So then they thought, well, maybe it's maybe it's their lifestyle, and these are miners. And when they're not in the mine, they were probably at the bar, and they were home and, arguing with their families, and and they weren't doing any exercise, and they weren't really much different. So other conventional risk factors really showed no reason for a lowered risk. So again, this led to this decades-long investigation. And it was finally decided and determined that it was the multi-generational families, the strong community ties, and the sense of purpose, place, and community. And it turns out that this purpose, place, and community was more powerful than their cholesterol, than their blood pressure. It's more powerful than any other biomarker. And it's something that's completely ignored. I was speaking with that guy right there. I was speaking to my buddy. He runs a really interesting program in Hawaii. Maybe you'll get a chance to talk about this sometime. Opposite of Atkins. Ornish, thank you. An Ornish program, and he was telling me that they kind of set this thing in motion, and then these groups, these communities kind of form, and they see that it's the community, the people, I don't know about his program, but in general, when you form a community, the behaviors persist, and people who fall out of the community, their behaviors don't persist. So sharing and having community, it's really important, and if you can build community, not make it about that little tiny room with only you and the patient and maybe a nurse. Make it bigger. Make it a group medical visit. Have coaches that help people create community, and we can get these kinds of outcomes because we know that these lifestyle interventions work. What we also know is it's really hard to do them, and without changing people's community, you don't change people. So, more powerful than any biomarker. It's story, meaning. Why do we tell the story? Because it's validating. It gives context for not only the path from ease to dis-ease, but back from dis-ease to ease and beyond that to true wellness. We create relationships, we create empathy, we create compassion, and we display love. So, what do we want to do? We want to think about points of leverage. We want to look at our model and think about points of leverage. So functional medicine, change the way we do medicine, change the medicine we do. If you want to travel swiftly, go alone. If you want to go far, travel together. I'll see you this afternoon. Thank you very much.